So how do we manage the disease process? So the first one, of course, is insulin, especially for your type 1 patient. We give insulin. Insulin in the past used to be gotten from the pancreas of cows and pigs or give to humans. But that was previously. We don't really do that anymore. Now insulin is made in the lab synthetically. Where do we give this insulin? It's given subcutaneously, meaning into your fat layer. Um, but we do and can give insulin intravenously, meaning into the vein. And the only type of insulin we give into the vein is the regular insulin. We'll talk a little bit more about the different types of insulin soon. If you haven't opened a bottle of insulin, you should be keeping your insulin in the refrigerator. But the moment you open it and you're using it, you don't have to keep it in the refrigerator anymore. Just use it at room temperature, which is the best way. You don't want to shoot a cold insulin into somebody's fat layer. It might cause what we call lipodystrophy. So, real briefly and quickly, we're not spending too much time in this. We're going to look at insulin, the different types that we have. We have four main types or categories of insulin. We have the rapid acting, the short acting, the intermediate acting, and the long acting. So, under the rapid acting, we have two. We have two types. We have the Lispro, also known as Humalog, and we have Aspart. There's a reason why it's called rapid acting. Whenever we're talking about insulin, we like to look at the onset, the peak, and the duration because that's important. So the rapid acting is called rapid acting because it literally starts working. That's what we call onset between 15 to 30 minutes of you giving it. So think about it. If something starts to work within 15 to 30 minutes of me using it, and what does insulin do again? It lowers your blood sugar. So imagine I take this within 15 to 30 minutes and I haven't eaten, what do you think it's going to do to my blood sugar? It's going to lower it drastically, yes. And I might go into a state I don't want to go. Then my blood sugar might be way too low. You see, diabetes is hypoglycemia, high blood sugar, but hypoglycemia is even worse. All right, a low blood sugar is not good also because your body needs that sugar to work. It needs energy. The brain needs it. Yeah. So what I'm trying to say is with rapid acting insulin, you got to make sure that that patient has food right in front of them before you give it. All right, it is given with food. With food. The peak time, what do you mean by the peak time? The peak, think about it as the peak of a mountain. The peak of a mountain is the tallest and highest point of the mountain. And that's kind of what this depicts. Pretty much, it means that this is where the insulin is doing its best job. It's at the peak. All right, it's extremely strong right now in your body. So, because of that, these are the times that you should come check your patient for potential hypoglycemia. Because when the insulin is doing its best job, that means that this is when it adds is most likely to drop your blood sugar the most. All right, so you should definitely come check on your patient during this time. Um, Let me give you an example. Let's say I give my rapid acting insulin at 8 o'clock. All right. Within what time do you think I should come check my patient for possible hypoglycemia? I'm hoping you said between probably like 8:30 to 10:30. Yeah, that's when you should be like the earliest you should come check your patient for possible peak hypoglycemia is 8:30. Right. And then duration is pretty much just telling you the total amount of period that this insulin is working in the body. So if I give my patient Lispro at 8 o'clock, it's gonna keep working for another 3 to 6 hours. All right, and then I might need to give another one. So short acting is also known as your regular insulin. Anytime we say regular insulin, we're talking about the short acting one. All right, it's also known as Humulin R or Novolin R. The R there represents regular. All right, this starts working in about 30 to an hour. It peaks at its best job at 1 to 5 hours, and it works for about 6 to 10 hours duration. Now, this is the one that you can give IV. All right, this is the one that you can give into the vein, through an infusion. When I say into the vein, I don't mean like you pull it up and shoot it. It's not an IV push. Through an infusion. All right, it's gonna be connected to a pump. And why we would ever have to give insulin IV? An emergency. All right, if somebody comes into the hospital with a blood sugar level that is ridiculously elevated, imagine us shooting that insulin into the fat layer. It's going to take hours to walk. All right, we don't have time for that. Now think about it. If I give a regular insulin, it naturally takes 30 minutes to an hour to walk. We don't have time for that. All right, this is subcutaneous, giving it into the fat layer. We need to lower that blood sugar right away. So in that case, we are going to be giving this V, because that starts to work in about 5 minutes or less. All right. And then we have intermediate acting, which is, we'll call that NPH. So we have Humulin N and Novolin N. So you can say Humulin can be regular or it could be N NPH, the intermediate. It starts working about 1 to 2 hours. It peaks in about 6 to 12 hours, and it has a duration of 16 to 24 hours. Now, all your insulins are usually clear in color, meaning they're transparent. You can literally see through them. But the only one that looks cloudy is your intermediate actin. Yeah, so it's not, it looks cloudy, it's not bad, it's not expired, that's its natural color. All right. Of course, if it has an expiration date and it is expired, then it is expired. But if you ever see a rapid acting or a short acting insulin cloudy in color, now that's bad. Okay. And then finally, we have your long acting, which is the glargine, also known as Lantus, and Detimer, also known as Levimer. This starts to work in about 70 minutes, and ta-da! This is the only one that does not have a peak. We call it a peakless insulin because it never peaks, because it never goes up the mountain. It's the only one that you probably don't have to worry as much about it ever causing hypoglycemia. All right, and it works for about 24 hours. So the best time to usually give your glargine is during the bedtime. That way it can just walk around the clock. Sometimes it's also given in the morning to walk around the clock. Because this insulin does not peak, never ever ever mix it together with another insulin in the same syringe. All right. Usually we mix our short acting and our intermediate acting. We can mix both of them in the same syringe and give it to a patient if the doctor orders both. But if the doctor ever orders, let's say, a short acting and a long acting, you gotta give them separately, all right, in separate syringe. Don't mix it together in the same syringe because it's gonna affect the way your long acting works. All right, it's a very special insulin. Don't mess with it. Okay. So now, where do I give my insulin? Subcutaneous layer. So your subcutaneous layer is your fat layer. So anywhere you see fat, you can shoot that thing in there. So the most common place, of course, is your abdomen. Just make sure you stay away from at least 2 inches, which is like 5 centimeter around the navel area. Don't give someone insulin inside the navel, please. Don't do that. Okay. Stay away from that area. But every other part of the abdomen, feel free. The upper thighs is another area. The back of your arm, where you have that fat part, is another good point. And of course, the upper buttocks area, the hips, those are good place too. If you can find fat, you can shoot it there. Now, the most common and the best absorption area, of course, is the abdomen because it's a bigger surface area than the other parts. Now, it's important in caution right there that you rotate your injection site when you give insulin. This is to make sure that you prevent what we call lipohypertrophy or sometimes called lipodystrophy. Because what's going to start to happen is you will start noticing that if we all keep giving that insulin at the same spot, you just want to teach your patient, this is the teaching moment right here. They need to rotate. With time, you will start to notice that the fat layer there is looking very thickly and lumpy. Not good. So we have to make sure we're rotating the site. All right. Now we've talked about insulin. The next thing we're looking at is oral hypoglycemics. This is usually for your type 2 patients. But you remember your type 2 patients might also need insulin when they're sick, when they're stressed, when they're going for surgery, or if they're pregnant. But aside from that, some examples of oral hypoglycemic is we have different classes also, but here are some common ones. We have the biguanide, is a class. The medication under this is metformin. Right, metformin is a big one. We have sulfonylureas, we have glipizide, glyburide, and we have meglitidenide. All right. Also, under this we have nitroglycinide and we have reproglynide. All right. So again, remember, oral hypoglycemics will only work if this patient is making some insulin at least, which is what the case of your type 2 patient is. All right. Now, diet. Remember, it's a threefold core treatment: insulin or oral hypoglycemic, diet, and exercise. So now let's talk about diet. What should my diabetic patient eat? It really depends. It depends. They definitely need to talk to the dietitian. Each patient might vary. There's no one size fits all rule to this. But the biggest important thing for whatever diet the patient is on to be effective is adherence, which is hard. I mean, have you ever tried to be on a diet? It's hard. Okay, it is hard. So this is the biggest problem that many patients will have to deal with, having to stick to a particular routine, eating on a day-to-day, consistent timing, consistent amount. That's hard on everybody. But we're gonna have to encourage your patient to stick to that. All right. So carbohydrate needs to be at least minimum of 130 gram per day. So some patients achieve this by carbs counting. They need to do more of fiber. Also, protein is about 15% to 20% of their total calorie. Then fat, they need to make sure they reduce the amount of fats that they're consuming, especially those saturated fat and trans fat, because these can put them at risk of a stroke and a heart attack. Also, with your type 2 patients, most of them are overweight or obese, as we've mentioned before. So they should actually be trying to lose some weight. All right. And consuming excessive fat, consuming excessive calorie in general is not going to help them to do that. All right. Exercise is very important. I like to think of exercise as the manual form of insulin. All right. Insulin is like your automatic, it boom, brings down your blood sugar. But guess what? Exercise also does the same. Exercise allows you to use your glucose, which is similar to what insulin does. It allows you to use your glucose, is the key. Now, exercise does the same thing. That's why exercise is important for your diabetic patient. They need to exercise. In fact, the more exercise they do, the more consistent they are, the less insulin they might actually need if this is a type 1. All right. So it's very good for overall functioning of their cardiovascular system, because this is one of the systems that starts getting affected as time goes on because of this disease process. It helps them to lose some weight, which is good. And it definitely just helps them to feel good altogether. Now, insulin can cause your blood sugar to go down. We've talked about that, right? Especially during their peak times. Now, exercise, like I just said, is also, it does something similar to what insulin does. It's a manual insulin. I could think of it like that. So therefore, excess exercise also can drop your blood sugar. All right, so you gotta be careful. So when your patient is going to work out, you gotta tell them to take a snack with them. But some of them, while working out, they might feel dizzy, they might feel fainty, which is probably a sign that they need to eat something. It's actually important that they eat something before they go exercise, especially if their blood sugar is less than 100. But if this patient blood sugar is ever greater than 250, they should most likely not exercise, especially if they're in diabetic ketosis, because that would just make things worse. It will make their ketosis worsen. They need to wait for that to clear up and that blood sugar to come down to closer to normal before they exercise. All right. The final thing we're going to look at today before we call it a day is complications of diabetes. Just running through them real quickly. Hypoglycemia is the first one. It's pretty much a fancy word for low blood sugar, low glucose level. This can happen to anybody. All right, whether you're diabetic or not, you can be hypoglycemic, but it's not good. All right, it's not good. It means that your blood sugar is low. And remember, this can be a consequence of too much insulin or too much exercise, all right, or just you even taking your regular insulin amount, but it's at its peak. So, what are some symptoms of hypoglycemia you might see? Think of tired, all right. So, T stands for tachycardia. Your heart rate goes up. It's one of the earliest signs of hypoglycemia. You just, and then irritability, are restlessness. E, the patient is so hungry because A, your body is just like, give me sugar, give me sugar. All right. And of course, D, we go into that depression, diaphoresis. The patient gets very drowsy. If we don't do something on time, this patient might even lose consciousness. Yes, that's how bad this can get because your brain just goes and it goes there. All right. If this happens, first you want to consider, is my patient still conscious or not? If they're still conscious, then please give them some sugar real quickly. All right. You want to find a snack that has about 15 grams of carbohydrate. They need that ASAP. All right, and we do the 15 by 15 rule, meaning that give them a 15 grams of carb. In 15 minutes, check their blood sugar. Is it back to the normal range of 70 to 100 or a bit above? If it's not, give another 15 grams of sugar and then try again in 15 minutes. So 15 by 15 rule. Now, if my patient is unconscious, it's a different ballgame. Please do not give anything by mouth. All right, if this patient is knocked out, stay out of their mouth, please. All right, instead, we're going to give glucagon. Remember, glucagon increases blood sugar. So we're going to give glucagon. This can help bump up the blood sugar and we can try to stabilize their sugar level that way. Now, diabetic ketoacidosis, on the other hand, this is an excess blood glucose in your type 1 patient, excessive blood sugar in type 1. Now, for your type 1 patients, they are the one who will go into diabetic ketoacidosis. It's very rare that you see a type 2 go into ketoacidosis. So, think of simple way to remember the symptoms you will see in this is DKA itself. D stands for dehydration. These patients are usually very dry and flushed. And think of K, ketonuria. They will have ketones in their urine because their body has gone into this ketosis acidosis. K also stands for Kussmaul respiration. It's a type of deep respiration that this patient, irregular respiration that they have. And then A is for acidosis. So they go into metabolic acidosis and they will have acetone fruity breath. Pretty much if you stay close to them during this DKA process, their breath smells very fruity. Okay? So these are the symptoms you will see in your DKA. Also, you can expect your blood sugar level to be about 300 to 800. Yeah, it's up there. So how do we manage this? Give them some fluid, all right? Because again, they're dehydrated, and also we're gonna give insulin. We're gonna give regular insulin, but we're gonna give it IV. All right. So this is where our IV regular insulin usually comes into place because we need it to bring down that blood sugar as quickly as possible. Now, the next one is hypoglycemic hyperosmolar non-ketotic coma, HHNC. All right, so this is excessive blood sugar in your type 2 patient. The biggest problem here oftentimes is dehydration. So, because the patient is not drinking enough water, they get so dry and sugar goes up. It's kind of like imagine putting a whole lot of sugar in a bowl and you just put a little bit of water that yeah, it's gonna be, it's just sugar, no water. Okay, so your body needs you to, that's why your diabetic patients drink water so much. But this patient is so dehydrated that it now causes their blood sugar level to be ridiculous. We're talking 600 to 2000. Yeah, that is bad. So the predominant thing that they need is IV fluids, but they might also need regular insulin to bring down their blood sugar. And then finally, we're talking about some long term complications. So, hypoglycemia, DKA, HHNC, they are usually short term complications that happen every now and then throughout the disease process. But as the disease progresses, we're talking 10, 15 years down the line, for some patients, it be sooner depending on how really bad their management is. Some complications starts to develop. The first one is retinopathy. So pretty much it can cause blindness. So they start to develop diabetic retinopathy. Also neuropathy. Those are your nerves in your legs, your body. So this patient usually starts to have some form of nerves issue. So it's either they're hypersensitive to to touch or anything, or they lose sensation. So they could be stepping on a nail and they wouldn't feel it. So we're very big on foot and nail care for this patient. All right, for your diabetic patient, foot and nail care is very important. Some things you want to do or teach them also is They need to wash their feet with mild soap and warm water. All right, warm water, not hot water. And before that, they need to test it. So if they're in the hospital environment, you make sure you test that water and make sure it is warm before you pour it on your body. If not, you could burn them and they wouldn't even feel it. But if they're home, they need to always make sure that someone else comes to check the temperature of the water before they use it so they don't accidentally burn themselves. Also, they need to pat their feet dry, especially in between the toes. All right, I'm gonna use my fingers because I can't show you my toes, but in between the toes need to be patted dry, especially. We don't want moisture because if there's moisture in that place, those places, those are the very common places that they start to have ulcers and wounds starts to develop in those moisture. So they need to really dry out in between those toes really good, or any other crevices in their body. They should use lotion. They can use lotion like lanolin. It's good. It helps the body stays moist, but don't put them in between the toes. All right. If they sweat a lot on their feet, then you might need to put powders on their feet so that it can stay dry. Again, the key thing is we don't want unnecessary moisture. Unnecessary moisture is not needed. You can cut your toenails, but make sure you cut straight across. If it's super hard to cut your toenails, then leave it alone. Let them go see a podiatrist, all right? Because you end up hurting them, and now they have an injury that will not heal anytime soon. We don't want that. If they have overlapping toenails, so if their toenails are those toenails that can like fold over each other, you might want to use like a paper towel or something to kind of separate them. So, all right, we need those toenails separated and breathe in. All right, they need to always have shoes on. They should never go barefooted. No flip flops. Covered shoes. The best kind of material for your shoes is leather. All right. So those are some things you need to do for their foot and nail care. And then the final type of complication is the kidney. The kidney gets affected. We call that nephropathy. So this can cause kidney failure for this patient. We talked about the hemoglobin A1C earlier. Remember, if it's 6.5 and above, that's bad. So we want it to be less than that. Anything 6 and below, now that's a good place to be. By the time we get into 7 and above, yeah, this patient needs help. Because the longer their HA1C is that high, the closer they will be at developing these complications, and it will get worse with time. Remember, again, this is just showing you some of the complications that the patient might have long term. It's not limited to the three we mentioned here, which is the eye, the nerves, and the kidney. They can also develop a lot of cardiovascular issues, stroke, hypertension. Once again, it goes back to the beginning when I said diabetes, it's a multi-system disorder, chronic, right? But our patients can try to manage them with diet, exercise, and taking their medication, which could be insulin or the oral hypoglycemics. All right. So that brings us to the end of this class today. I really hope this was helpful, and thank you.